morning to introduce our next speaker, Dr. Selwyn, who is the Professor-in-Chief of Trauma and Accurate Care Surgery. Please welcome Dr. Roger.
Thank you very much, Stacy. I'm a little taller than Stacy, so I'm going to adjust the mic and lean in a little bit. I want to thank the organizing committee of the Social Medicine Consortium for inviting me and giving me a few minutes of your precious time. And I realize I'm standing in the way between you and lunch, so I will be brief. I'm going to try over the next 13 minutes to reframe the discussion around intentional violence on the South Side, in the city of Chicago, in the United States of America. I'm going to try to do that from a public health lens. But before I actually can do that, I think it's important to start with a few definitions. What is health? The World Health Organization defines health as a complete state of physical, mental, and social well-being, and not merely the absence of disease or infirmity. With that framework, what is violence? Violence is the intentional use of physical force or power, threatened or actual, against oneself or another person, or against a group or community that either results in or has a high likelihood of resulting in injury, death, psychological harm, maldevelopment, or deprivation. And I think with that broader definition of violence, one would say that we live in a violent society, because the impact of social determinants of health, like poverty, discrimination, racism, lack of economic opportunities, are all things that lead to deprivation and are contributing factors to what we see as the end result of intentional violence. And I'll posit that there can be no health if there is no safety. Those of us living in communities that are disproportionately affected by violence cannot be well, because physical safety is a ground floor for wellness. With that as a framework, I find it, and many people in the room find it, I'm sure, alarming that there were 764 documented homicides in the city of Chicago last year. But I challenge everyone in the room and those not in the room, why is 764 more alarming than 485, more alarming than 416, 421, 506, 437, or 437 over the past 10 years? All of those are lives lost to intentional violence, and not just to those who have died prematurely, but also those who have been touched by the loss of those lives: fathers, sons, mothers, children, parents. And in the context of that reality, communities, because everyone is touched by the impact of violence in the context of the world in which we live. But Chicago has become a poster child. I actually hail from, I like to say I'm a citizen of the United States of America, or a citizen of the globe. I was born on St. Thomas in the United States Virgin Islands, but I've had a meandering course of my professional life that spanned Baltimore, Boston, Nashville, Philadelphia, Galveston, and now Chicago. Chicago became a bit of a poster child for intentional violence if you look at social media, popular press, and our president. But if you actually look at the reality, intentional violence, particularly homicide rates, the city of Chicago is not number one in this category. It's actually the city of St. Louis, to our south. And I think many people in the room will be surprised to learn, if you didn't know already, that Milwaukee is number 10. Or that Hartford, Connecticut is in the top 20. Or that Chicago is actually number 24. That does not make any of those numbers relevant, because they don't really tell you the life and the experiences of all those people lost and the impact to their families. But this is a problem of urban America. This is a problem in the context of a whole host of social determinants and structural violence of communities that disproportionately lead to some being harmed more often than others. And this is not a new problem. If you can read the caption, "Crime in the Ghetto, Everybody Pays the Price." This is from September of 1985. "Blacks suffer most, but urban terror touches us all." This is not a new story. And there's been efforts by many to address this problem, but maybe one of the problems is that we're asking the wrong question or looking at the wrong solution because of the way the problem is framed. One significant factor was this issue of access to trauma services on the South Side. The outcome of an incredible amount of effort on the part of many, the power of advocacy, the power of people working together for a common cause, led to the eventuality of a trauma center at the University of Chicago Medicine, and in many ways, without the activism of many and decision-making by some not in the room, I would not be on this platform today. So thank you all for this incredible opportunity to help reframe the discussion of intentional violence as a public health problem. When I actually look at this set of problems, it's complicated because I think if you create a framework that this is about bad people doing things to bad people resulting in injury, you miss the opportunity to intervene. Oftentimes, we look at violence as an episode, an instant, a moment, but don't consider the longer-term arc of people's lives that put people at risk over the course of their life for being the victim of or the perpetrator or both of violence. And that violence comes in many different forms. It's easily measured in the context of a homicide. If you read the paper today or tomorrow or the next day, you'll see a name, you'll see a geography or an address, and you'll see a time. But you won't see a story. And you certainly won't see a story of how that event came to be, or the structural violence, the impact of economic divestment over decades, if not generations, that have led some people and some communities to be disproportionately affected by intentional violence. And I think it would behoove us not to be able to use words like racism, oppression, systemic structural violence as ways and methods to address the upstream factors that lead to some communities, some people being disproportionately affected by intentional violence and the resulting impact on communities. One of the things that's really amazing is the power of science to better understand a problem. So this is a paper by one of my mentees, Bethany Strong. She did a set of studies using the University of Maryland Trauma Data Registry. And this is, for those in the audience, it's like a survival curve. And the top curve are people who, all these people are people who have suffered trauma at one point in time, over a 10-year period in the city of Baltimore. The top graph are people who did not suffer a second event of trauma. At the time zero, everyone survives the initial injury. The top graph reflects those who do not suffer a second episode of violence. The bottom graph is anyone who suffered any episode of violence. The reality is what you're seeing is all-cause mortality, not just from violence, but from the impact of diabetes, uncontrolled hypertension, systemic factors of access to care, and just having access to medical care does not equal equity. And so the challenge for many of us in this room is how do we actually achieve equity without addressing social determinants of health or the structural systems in our society? And to really address intentional violence as a public health problem requires true intersectionability. And when I say intersectionability, it's really the impact of all of these factors: community engagement, access to recreation and open spaces, access to healthy foods, access to medical services, public transit, quality affordable housing, economic opportunity, legal representation, environmental quality, arts and culture. Those are all the elements of health. And any missing one of these seemingly separate siloed bubble leads to deprivation. And it's the opportunity to intersect all of these, which will be our way forward to address this daunting problem. I know Commissioner Morita showed this slide yesterday, but I'm just incredibly struck in a world-class city like Chicago that there can be an average life expectancy in the Loop of 85 years of age. In Washington Park, which is only a quarter mile from your Chicago Medicine, 69 years of age. 16 years difference, 8 miles, 7 stops in the L in 2016 in this great city of Chicago. And I challenge everyone in this room to think about the important role of the spheres that you influence and the important role of advocacy and community engagement to address these really challenging problems. Solution to them will lead to a better world for all of us. So with that, I'm going to end. I want to thank the organizing committee for the opportunity to share a few words updating where the trauma center is at University of Chicago, its evolution, and to thank you for the opportunity and privilege of sharing a few comments today. Thank you.
Special thanks to Dr. Roger. In the name of the consortium, I'm ending with this book.